So next I'm going to introduce our presenter, Dr. Andrew Lohoar. Dr. Andrew Lohoar wears a variety of hats in our emergency department, provides a tremendous amount of leadership. And today he's going to be talking about urinary retention in the emergency department. So we're still recording. So Andrew, I'm going to go ahead and give it to you. And
thanks. So I'm going to share my screen here. Alrighty.
Perfect.
You can see that?
I can see that.
Excellent. I want to thank Robin. We're going to change gears here and we're going to talk about the emergency delivery of urine, not babies. I put this this slide in for Dr. Van Hoot. It's a statue in Belgium, but I don't know if he's on with us right now. It's called the Statue P. We're going to just go through a few of, I guess, some basics. We're going to talk a little bit about the sort of the physiology of acute urinary retention, the etiology beyond just BPH. And then I want to sort of open it up. We're going to talk about what we should be doing in eMERGE, some of our treatment decisions, and then what we're currently doing when we send them out of the department, and what would be the best evidence about disposition. I'm going to start with a little video here that somebody sent me. This is, we have sort of the equivalent. We have a surgeon who's also a comedian named Dr. Hassan. This guy's an ophthalmologist who's also a comedian and likes to have a take on other specialties. I thought you guys would enjoy this.
You stuck a what up his? A top hat? Oh, one of the little pieces from Monopoly. Oh, okay. Yeah, no, anatomically that makes a lot more sense. Yeah. Okay, I'll be by later. Okay, bye. Come on in. Does that happen often? Nah, it's usually either the wheelbarrow or the rocking horse. Oh, I mean sticking things up the, you know. Oh, yeah. As long as there have been penises, there have been men willing to stick things up into them. Oh, I think I'm going to be sick. You're going to be fine. We actually don't examine that many penises in urology. Really? Oh, we see so many penises, like an aggressive number of penises. Hey, doc, sorry to bother you. I got a consult for you. Bill, come on, buddy. None of us can get the Foley in. Nurses, residents, med students. Well, what about that guy? That's Tony. He's a maintenance. Yeah, he can stake a drain.
So just to set the scenario, we're going to talk about what we're going to do when people need a Foley catheter and how to troubleshoot that. And I'm also going to sort of give you a scenario here about the sort of problems that might be more common in our peripheral sites when people come in. Say this guy who hasn't been able to pee for hours. He's pretty uncomfortable. And you have to sort of approach them, how you're going to manage this guy who's in acute urinary retention. So the definition is painful, palpable, percussible bladder, and somebody can't pee. It's not always easily perceived by the patient. You got to think about people with sort of spinal cord issues or neurological conditions. It also can be confused with people who think they just have urinary frequency and they actually are in acute urinary retention and they're actually experiencing overflow incontinence. The physiology behind this is a little complicated. This might bring you back. It's quite a complex communication between our central nervous system, the peripheral nervous system, and the lower urinary tract. The two, there's sort of a dance between our parasympathetics and the sympathetic chain. The parasympathetics sort of through the pelvic nerve are lower, sort of in the cauda equina, and it's those parasympathetics that are really needing to sort of be working to allow somebody to urinate or to pee The sympathetics are sort of higher up, and they are more to sort of stop you peeing. So if you think about parasympathetics allowing you to pee and sympathetics allowing you to stop peeing. So we think about sort of the mechanism as being sort of mediated from above, from your micturition center. You get that sensation that you've got to pee, and you've got the parasympathetics have to be intact to sort of allow relaxation of the detrusor muscle and your internal sphincter. And then there has to be some sympathetic relaxation to allow you to pee. There's also the somatic fibers, which are the only thing under the person's control, which have to be relaxed to allow micturition. So we're going to talk a little about sort of the etiology. We all know about the most common cause, structural, intrinsic, BPH, 75% of cases, but we have to sort of avoid sort of anchoring or a bias. When somebody comes in, we automatically think it's that, especially in older patients. There's also extrinsic causes, malignancies. There could be blocking with clots, bladder calculi, and then even just without examining somebody, it could be a phimosis, right? So we have to think about extrinsic causes. The iatrogenic ones, pharmacological come to mind. First and foremost, there's just a long list of medications that may cause. So anything that's blocking your parasympathetics, your anticholinergics, your antihistamines, a lot of analgesics, benzos can do it, antipsychotics, anti-Parkinson's. And then think about your sympathetic, your stimulants, which are going to cause an inability to relax that internal sphincter. So when you have people coming in with sort of sympathetic sort of abuse, or just maybe somebody who's obtunded, you have to think about might actually be in urinary retention if they're involved. Non-pharmacologic, probably the number one cause are, urinary tract instrumentation in the past, previous catheters, any recent surgery can cause an obstruction. Infectious, your inflammatory narrowing is usually, urinary tract infections or, recent instrumentation. It might be a combination of structural plus an inflammatory infectious sort of obstruction. And then always consider sort of neurologic stuff. It might not always be just, it might be mediated by, a chronic disease. Diabetes is probably one of the more common causes, but thinking about previous strokes, and then obviously cauda equina, if there's any sort of condition with back pain or previous back issues. But the home point here is just as soon as somebody comes in and you're told that they're in retention, go through all these potential etiologies, not just structural, but these other ones when you're considering why. The physical exam, it should be sort of a directed physical, but again, when you're thinking of the different etiologies, it sort of directs what you're looking for. So back pain, a quick neurologic exam of the lower extremities. Like I said, you should consider anybody with delirium or an altered level of consciousness. This should be part of your workup, is to sort of rule out anybody who's also in retention. We can easily make this diagnosis with POCUS, obviously, and we all have bladder scanners that we can use. The labs, limited sort of use. It's as far as the diagnosis goes, but we'll probably want to know your sort of urinary function, rule out any renal failure or sort of secondary failure from obstruction, and we'll usually send a urine for you for culture and maybe urinalysis. As far as calculating volume. If you don't have a bladder scanner, I threw this one in for Dr. Lewis. There's a few different formulas, but essentially you're just calculating volume, sort of width by depth by height. And depending on the shape of the bladder, there's sort of, there's a correction coefficient, which in general is around 0.7. So you can sort of calculate the volume just with a probe and a few quick measurements to, you know, when you're actually assessing the patient, and instead of wheeling in the bladder scanner, you can have an idea of how much urine is in there. So that sort of brings us sort of through to the treatment. And these are our goals. We want to decompress that bladder and fix or treat any of the potential other causes. I guess, you know, infection would be something we could do something about. But we want to mitigate any of those other causes of retention. So back to this fella. We asked one of our LPNs to try to put a catheter in, just a standard catheter, and it fails. So I don't know if we have any learners on, but does anybody sort of have an idea of where to go when they sort of come to you and say, I couldn't get the catheter in? What would be sort of the next step approach for a patient like this? Does anybody have any approaches?
What's the pager number for urology?
Yeah, exactly. So you're in Charlotte County, and you could have a little chat with them. I guess you have to think about why it failed. But in general, sort of go back to the basics, make sure you should be even attempting this in the first place. So you want to know about recent surgery, certainly with trauma. You know, we all know blood at the meatus, if there's been any trauma, is sort of a no-go until you have a urethrogram. But in the context of somebody you think you can really, you know, maybe try something else, make sure they're well anesthetized. Sometimes there's just a lot of discomfort will cause people to sort of not relax, and it makes it a little harder. The standard tip Foley is usually the starting point. You know, bigger is usually better in people with enlarged prostates. It just has a little bit more sort of rigidity, and it's less likely to fold on itself. The coude tip, in talking to the urology colleagues here, think this is really should be our first. For some reason, I think there's a policy amongst staff or people who are trained to do this, that they have to start with a regular catheter. If it fails, then they can go to the coude tip. This one really makes a lot more sense in somebody with prostatic hypertrophy, because it's got an angle to it, and that should be definitely the second go, and it might help you sort of angulate and get back through the prostatic urethra. And then if that fails, a celastic catheter is a skinnier one, better probably for urethral strictures. It's rigid, but usually a smaller sort of French size to get through some narrowings. It's really important not to cause any sort of iatrogenic complications. These multiple attempts really can cause difficulty down the road, make it more difficult to finally get a catheter. So if you're getting resistance, back off and think about what you can do differently. And probably the number one cause is repeated forceful attempts into a false passage, which you can sort of see in this picture. It's just as you're sort of getting to the prostatic urethra, the false passage usually forms right there. And you can see there's sort of an acute angulation. They say this maneuver sometimes can help sort of fold the tip or guide the tip, but you can see how a coude tip will sort of make that higher degree of angulation, that turn, a little bit more easy. And the other key is never to inflate that bulb unless you've got return of urine and you've pushed the catheter almost to the Y junction. Sometimes you'll get urine return when you're just past sort of the internal sphincter, but you're not quite into the bladder. So urine can be returning and you don't have that catheter well into the bladder. So make sure it's all the way in before you inflate. So you've tried all that and you can't pass the catheter and there's a blizzard outside. So now what? Any ideas?
Get a needle in there.
Put a needle in there. I think that's right. And this is in our wheelhouse, right? But I would make the argument today that this thing should probably be retired and put on the same pile as our chest tubes with the trocars, right? I think it might be time. This old suprapubic catheter kit is sort of it's pretty barbaric. You sort of just stab it in there. There's all sorts of stories of this sort of going through and through. If you know, it's sort of a, I mean, you're obviously going to have a look with an ultrasound first, but it's certainly not a very sophisticated way to do this. So what would you do as far as what would you use, Kavish, as far as a kit or a way of getting in?
So the last time I had to do this, I was in Charlotte County. So Teresa and them might remember. I actually just took our the 16 gauge angiocath, and with ultrasound, just found the biggest pocket that I could, and then just introduced it and decompressed, and just took a large syringe to decompress the bladder enough to basically get me 110 kilometers to St. John.
Nice. That's good. This is just a quick video here.
Percutaneous suprapubic cystostomy.
In a
Any catheter that can be used as a central venous catheter can be inserted suprapubically with the Seldinger technique. Enter the bladder with a syringe and needle. Confirm location by aspirating urine. Remove the syringe and pass the guide wire through the needle into the bladder.
And this is just a central line kit this guy's using.
Subcutaneous tissue is dilated.
Like a big cordis.
The catheter is passed over the wire into the bladder, and the bladder is decompressed.
So that's it. So that's all we probably should be doing. I actually asked our urology colleagues if there's such a kit, and it exists. They have this in the OR. And I'd probably move that we could put this on our urology cart. And I can leave the sample I have in the back room for a look, but it's everything you need to do a Seldinger technique. And there is actually a catheter in that kit. It's a Silastic, it's a 16, but it's got everything you need. It's got the little scalpel for nicking the skin. It's got an introducer needle, and then there's something on the right-hand side is a long wire. So the wire's there, and you can see the dilator there, and then you just sail the catheter over the top. So this is probably something we should be using as our first go-to for suprapubics. And there is some argument in the literature that you know, you could even consider it first line. It's nothing that anybody here, when I've discussed it with the urologists I was talking to, aren't really on board. But this was an old study out of Ireland where they looked at men 100 guys came in with urinary retention from prostatic hypertrophy. And they compared, I think, 30 or so that just had urethral catheters to this group that they put in suprapubics, and they had, you know, decreased complications, decreased infection risk. They don't get the urethral strictures. And the beauty is that when they go to clinic in a week, you can do a trial of micturition without taking the catheter out, right? You just clamp it, and if somebody can pee, then you take out your suprapubic. And believe it or not, they're sort of as well or better tolerated than a urethral catheter. So there are some arguments to say this could be the way to manage people that are in acute urinary retention. I would say, you know, it's an option, but it has to be sort of decided through the, you know, with a urologist who is going to be following the patient. Has anybody ever sort of seen people using this first line, like say in Britain? No?
No, it was like a backup in case it failed. You know,
Yeah.
It was always second line. It was never a backup.
I mean, the only difference, I guess, in the UK from here is that we didn't, I would certainly not where I worked, we didn't have LPNs to do the catheterization in the emergency department. It was basically the physician who did most of the catheterizations. And that would be the only thing that I would think, you know, here, if you're going first line, you're basically transferring a role that is being done by an LPN to a physician. So that would be increased physician time. No,
that's a good point. No, I just thought I'd throw it out there to say that this isn't, you know, sort of unprecedented, you know, and it wouldn't be substandard care. It's just, you know, tradition, and that, you know, it's urethral catheters have always been sort of a first line thing, but it's not worse care, and something that certainly in our wheelhouse with ultrasound guidance and you know, our ability to use Seldinger technique for many things. Another sort of consideration after you've got a catheter in is this slow versus rapid bladder decompression. And the jury's sort of in on that one, that, you know, having to clamp it and then wait, and then, you know, people used to say never take off more than a liter at a time. We sort of found that, you know, people will sort of bleed. There is some sort of dilation of the veins, and as you decompress the bladder, there's sometimes some bleeding if you go fast or slow. So I think we can just put the catheter in and let people drain. We also, I was of the mind that once the catheter in, we can just put a leg bag in and let these people go. But we probably want to check to see that they don't have sort of what's called a post-obstructive diuresis, where sometimes if there's elevated renal tract pressure, people have an inability to concentrate their urine. It's sort of renal dysfunction. And then when you release the pressure, they sort of have this diuresis, and they can put out great amounts of urine. It's almost always in people who have abnormal renal function. So I think you should at least wait to see what people's renal function is. And if it's normal, then the chances of, you know, having this post-void diuresis is almost zero. So I would keep people around till at least you know that they have normal renal function, and then they'll probably be good to go. But we can just let things go as far as the urine drainage goes from the get-go. And then treatment, alpha-adrenergic blockers are sort of standard of care now. This is a Cochrane review, and it's looked at many randomized controls trials. It's not great, but there's moderate. It's probably of moderate use as far as success in the challenge when it comes a week later or a few days later, taking that catheter out, that they won't have recurrent retention if they're on an alpha blocker. So if you think it's from BPH and they're not on one, we should probably be starting this so that they're more likely to have success when the catheter comes out. It's not going to stop surgeries. That's not what the the studies were there to prove that, you know, it decreases the amount of surgeries down the road, but it does improve the success rate, probably from 40% to 60%. If you have them on and they've been on for a few days, one of these alpha blockers, and we traditionally use Flomax. And that's what most of our urology colleagues would recommend. As far as follow-up goes, there's fairly good evidence that getting people in sooner rather than later leads to fewer complications. And you know, you don't want to take the catheter out too soon, but a lot of studies sort of show 3 days is all you need. Sometimes when there's huge volumes and huge retention, you might want to let things settle a little longer, up to 7. And I think 7 days, when talking to the colleagues here, is more realistic, because most times they only have 1 or 2 clinics a week, and they say send them to the next clinic. So it could be up to 7 days. But I think that's what we should be requesting, is next available clinic. We don't want these people to, you know, have to maybe call for themselves and then not get in and be walking around with a catheter for a month. That's not, it's not good care. So make sure you're arranging urology follow-up and ask for it to happen within 7 days. And then there's a few people that need to come in, right? People who have acute kidney injury or septic, any other concerns, they wouldn't be able to manage a catheter at home. But probably, you know, the acute kidney injury is something that should give you pause, and definitely discuss with urology before sending those patients home. There are a few special populations. These populations, we don't see acute urinary retention very often at all. And they again should give you sort of pause that there's often higher incidence of serious diagnoses. Peds have often congenital stuff, higher likelihood of infectious causes. Probably the most common cause is posterior urethral valves. But we should be discussing probably every pediatric case, and in women as well, higher incidence of neurologic and structural etiology. So they need a more thorough workup. I'm not going to get into any details. It's uncommon, and it should give you pause. There's something more going on. So in conclusion, I thought it's just important to really think about all the different etiologies other than structural. Stepwise approach, think about what you can do to have a successful, and try to avoid the multiple attempts, because every time you're more likely to cause damage and probably urethral strictures and false passages down the road. I think we should get rid of that trocar and use our Seldinger kit. I'll try to get that on the cart. Antibiotics, there's no need. Maybe in cases where you've tried multiple times and you've had a complicated or, you know, a difficult time getting catheterization, maybe a one-time dose, but these people don't need routine antibiotics. They should be discharged with an alpha blocker, and we should be getting them followed up within 7 days. And that's it. So any questions or
That's great. Thank you very much, Andrew. Rachel had a question with regards to post-retention diuresis. Is there any consensus on admission in addition to what you said with respect to the elevated creatinine?
I think if they have it, they should be admitted. To diagnose it, I think it's over 200 mils an hour for over 2 hours. Most people say 4, but anything over sort of 2 hours would be considered you know, positive for the diagnosis. And like I said, it's almost unheard of in people. I mean, these are kidneys that have been insulted, and they should probably have a bump in their creatinine, something going on, abnormal electrolytes. So there'll be that, along with this persistent high output diuresis, and they probably all should be admitted. They can get pretty sick. I think it's more just waiting for things to settle down, but they often need high they need big fluid replacement, and they need to be watched quite closely.
Andrew, did you
Yeah.
read anything about keeping catheters in the fridge or the freezer to make them a little easier to guide in? That was something that we used to do in the UK. We'd always have one or two.
Probably with a regular catheter that would make sense. Again, often the problem because BPH is the common problem we're going to encounter, you can get through the urethra as far as sort of the prostatic urethra, and you need sort of a firmness there. Plus, you have to make that angle. So that's why people would say use a bigger catheter, like maybe, 18 French, even 20. And that would be the same thing. I think you're just looking for something that's just got a little bit more
Rigidity.
Yeah, rigidity to it.
Yeah.
But I hadn't heard about keeping them in the freezer. It's sort of a neat thought. But the urologist was saying it drives them crazy that we can't just start with a coude tip. It's going to be the highest likelihood of success, but they don't let I think they just have a standard. You've got to go with this catheter, like the normal Foley before you go to the coude.
I like the tip of the Seldinger.
Oh yeah.
And I think you mentioned that draining, just the needle aspiration to buy time. But I guess really, if you've got a needle in, you may as well stick a guide wire through it, because why do it twice? I think first needle in there should be the last needle in there.
Yeah. And I mean, the days of, worrying about bowel perforation, with the blind techniques with ultrasound, that hopefully that'll be a lot less likely. And I thought we might have an opportunity here, if we're doing these simulations with cadavers, whether we could actually sort of add this to the procedure list, just to get your sort of hands on the kit and the steps. It's pretty simple, but still, just to have done it once, we could fill the bladder and then just clamp the catheter, and we could maybe have a go at some suprapubic catheters in the lab. So some sort of food for thought there.
I think that's a great idea.